thank you for attending the workshop. Today's workshop is presented by Stanford Healthcare Tri-Valley in collaboration with the Tri-Valley Chambers. My name is Christy Malsack, and I am Director of Member Services throughout the Chamber. And today's topic will be advanced healthcare planning. And Manon Carter is social worker social worker supervisor at Stanford Healthcare Tri-Valley. And she is a medical social worker who's been employed with Stanford Healthcare Tri-Valley for over 25 years. She is a licensed social worker with certificate in palliative care and advanced certification in social work and case management. She believes that patients should be proactive in making their healthcare decisions, known being via a healthcare directive, living will, and or physician's order for life-sustaining treatment, form POLST. So welcome, Manon. Thank you so much for being with us today, and the floor is yours.
All right. Well, thank you for joining us. I think it's important subject matter. Since I've been working in the hospital so long, I see when this really comes in handy. I'm going to share the screen so you can see my slides here. That one right there. And are you able to see that?
Yes.
Okay. All right. So in the hospital, just briefly, what I'm seeing is when someone is in dire need of medical care and they need a quick decision made. Oops, there goes my screen, sorry. We're looking around for who's the decision maker. And you think it'd be easy. If there are people that come out of the woodwork that say, I should be the decision maker. You know, I'm the brother, I'm the sister, I'm the ex-wife. Really, I was with him for 20 years and I should be this. Oh, this lady's just the girlfriend. And, you know, you just get in this whole mess. So to have an advanced directive really makes it easier for staff to really concentrate on what's important, right? Not worrying about all the social dynamics. And it gives the patient the power to really have done what they want done, right? And there's vehicles to do this. So right here it says Advanced Healthcare Directive. That is the one. I'll go over it more in depth, but Advanced Healthcare Directive is pre-formatted. It has most of the language on it that you need. Just fill in the blanks. So you're stating, I want so-and-so to be my decision maker if I am not able to make decisions. It has space for a number 2 person, even a number 3. So you can put those in order. And sometimes, even though you named that person, that primary person, they say, no, I'm not really comfortable doing that. Can you go to the next person? So we've done that as well. So what I'm recommending is that you really do have that conversation before you fill that out to make sure that you put down the right person for that. The living will, another avenue that you could go, it's more specific. So where the Advanced Healthcare Directive says, so-and-so will be my agent if I'm unable to make that decision. And there's some other things you can check off as well on the Advanced Healthcare Directive, which I'll show you. Living will is where you get into the nitty gritty. This is where I want to leave I want to leave my house and the things in my house to my children equally. But what happens if one of those children dies? Are you going to implement it so that it goes to the grandchildren or someone else? Do you want to go into a charity? It gets into all those very minute details that Advanced Healthcare Directive doesn't. The Advanced Healthcare Directive is really geared towards medical professionals taking care of you. Living will, that'll spell out exactly your wishes and exactly, I want to have a funeral service, I want to have doves released, you know, that type of thing. It gives you space to have every detail in there. So they're all good. They're all good to have. I have an Advanced Healthcare Directive and a living will. Now the pulse is a little different. This is for people that have had a serious illness for some years. They have an end stage diagnosis like congestive heart failure, chronic obstructive pulmonary disorder. They might be end stage cancer. These are folks that if a doctor is treating them, they'd say, I would not be surprised if that patient passed away within a year. Like it wouldn't be that unusual. So that's a different form that they can fill out that is actually a doctor's order. I'll get a little bit more into that, but I'm covering those. The one I'm not covering, but you should know, is a general power of attorney or otherwise power of attorney for finances. People bring that into the hospital all the time and they go, no, this is it. I go, no, that's not for healthcare. And they said, no, it says healthcare in the form. I go, that's not what they mean. That's, it's not how you want to be treated. It's just telling you, like, you can choose that place for the patient. That patient can go there and you're going to help pay for the skilled nursing, that type of thing. It says you can sell their property, you can manage it. So when people bring me that, I said, well, that's nice to know that the patient trusted you enough to put you on that form, but that doesn't have power here. But if I had to search for next of kin, good to know that you were very important in this patient's life, but we still have to investigate and see who else. So good to have that as well. That's a separate thing. But I'm just going to concentrate on what would pertain to healthcare today. All right. And by the way, let me know if you have any questions as we go. So the Advanced Healthcare Directive goes by many names. Medical healthcare power of attorney, and most people just say power of attorney. I like to specify power of attorney for finances or power of attorney for healthcare. They're different, right? The patient names the person, or whoever's in the community names the person that's going to make decisions. They go by a lot of different names out there, so you just have to know that. We say healthcare agent in the hospital, but you'll hear healthcare proxy, surrogate, healthcare representative, healthcare attorney, in fact, patient advocate. It depends how you use that. A healthcare surrogate could be, you're in the hospital and you're alert and oriented, you can tell me what you want, but you never did this directive. I need to know from you, who would you name to make decisions while you're hospitalized? And that happens, that sometimes they get confused and all of a sudden they can't make their decisions in the hospital. So I'm saying, who's your surrogate decision maker? So that's what we put in the chart, and we have power only to act on that with that person during the hospitalization, but once they're discharged, that has no legal power. Okay. Advocate, sometimes we're asking, do you have a close friend, a neighbor, someone, some people have had that neighbor for 40 years and they've been doing so much for our patient. And we will take that into account to have them tell us, what do you know about this patient's wishes, that type of thing. So it can get confusing when people are throwing around so many different terms. We usually just refer to what the document says. Okay, any questions on that? No? Okay. Okay, do you need this? Well, I think everyone should have one. There's a lot of assumptions made, like, of course it would be my wife or my husband or what have you, but not always. Sometimes I find that they don't want the spouse, they want the brother or sister or what have you. So it's really good to know who do you want for that actual decision making. It'll probably come to us, be a shock for the patient's spouse to find out they weren't the ones chosen, but sometimes people don't act well under pressure, when there's a crisis, and they know that so-and-so acts very calm and understands me very well. So very easy to complete this form. You don't have to go to a lawyer. You can have 2 witnesses, and there's instructions on who can be a witness. So you're not going to have your healthcare worker. You don't want to have your witness be the person you're saying is going to be the agent. It's nice if you can have an outside party. And if it gets a little complicated with what person do I choose to be on that form, you can go to a notary. You can go to that UPS store and show them your ID, and they'll look through the pages, make sure you initialed what you need to initial, if there's anything like that to do. And for $40, you walk out of there. And if it's a mobile notary, it could be 40. It could be as low as 15, depending on where you go, just to get that signature. So once you have that done, you keep the original, you give copies to the people you've named on your document, give copies to your doctor, and it's great to give it to the hospital. If you're being admitted for anything, it gets scanned into our computer or whatever hospital you're going to, and we'll always have that for reference. So that's a very easy thing to do. And this is the one that we use. This is from the California Hospital Association. It tells you the instructions. Excuse me. And we like to have the name of the patient. If we're giving this out, to fill that out so we know just from the first page, who is this for? And when they're in the hospital, we like to put the patient label on as well. Okay, second page, this is where we fill out this with the patient. Designation of the agent. As much information is good. If you put a name down, it'd be great to put a little slash in what relationship they are to you. That gives us some context of who we're putting down. It has the second line where you could put your alternate agent. The first one is not available or decides I don't want to be that agent, you can go to the next. There's another one, so you can have 3 people listed. Agent's authority. My agent is authorized to make all healthcare decisions for me, including decisions to provide, withhold, or withdraw artificial nutrition and hydration and all other forms of healthcare to keep me alive, except as I state here. You can put in very specific details of what you want, what power you're giving that person. Most people do not put anything in there. They're just going to trust the person they named to make that decision. Hydrated. The next page. Now, this is a little tricky. You can choose in the first line, my agent's authority becomes effective when my primary physician determines that I'm unable to make my own healthcare decisions. Most people will choose that. That makes sense. If I can't make my own, great. The other one is it takes effect immediately. That's rare, but I can tell you my mother chose that because she says, I have the capacity, but I'd rather you do that because you work in the healthcare industry and you understand the lingo, you understand that, and you know exactly what I want. That's rare to have someone put that. But when they do, we will go to that person and say, okay, they want you to make decisions, but we really still try to involve the patient in all the decisions. It's kind of scary to give away that power to someone when the patient's right there and is totally alert and oriented. So we do it more as a group collaboration. Okay. You can talk about anatomical gifts. Some people skip this section altogether because they go, I don't know, I've never thought of this. I'm like, that's fine. So here, my agent's authorized to make anatomical gifts, authorize an autopsy and direct disposition of my remains, except as I state here, or in another part of the form. So some people have really strong feelings like, I'll donate as long as it goes to, such and such, or it's used for this reason. A lot of people have strong feelings like, I don't want to give anything from my body if it's for cosmetic purposes. They want it for medical research or things like that. This does not have to be filled out. Okay. The instructions. Okay, this is a little gray, and this is why the pulse form was made. Do you choose the choice to not prolong life or to prolong life? What does that mean to you? So For here, it says, I do not want my life to be prolonged if I have an incurable and irreversible condition that will result in my death within a relatively short time. Okay, what's relatively short? We don't know, right? You could also specify that if you're the person filling this out. I become unconscious, and to a reasonable degree of medical certainty, I will not regain consciousness, like the person that will be on the ventilator, for life, that type of thing. The likely risk and burdens of treatment would outweigh the expected benefits. We do see that. We see that in ICU, where we're doing so many things that the patient's hooked up to, so many lines and what have you, they can't get off. Or the treatment, sometimes it's, it could be a cancer treatment. It's you might treat some of the cancer, but now it's making you feel horrible. So you have to, are you a quantity of life person or quality of life? And that's what it comes down to. So the person that says choice not to prolong life is more worried about the quality of their life. So you go down to the choice to prolong life. I want my life to be prolonged as long as possible within the limits of generally accepted healthcare standards. What is that? That's a gray area as well. I would say our doctors are very good at weighing all of these things. I mean, that's a lot of trust you have to have in the doctor as well. Some people say, well, you're just trying to get in bed. You're going to withdraw everything. So some people say, no, I want to prolong life, keep me on because a miracle might happen. Hey, it might. I've seen them here. We don't know. How long do you want us to keep going with all the treatments that we're doing for you? Is there an end point? And that's when I go to that agent on the healthcare directive and go, well, is in your mind, is there a time frame that we do this? When is enough enough? Or are you okay with sending your loved one to they call them LTAC facilities, the long-term acute care facilities, where they can live there in theory indefinitely. So we have to really hone that in. So it's really good if you're doing one of these to think about that. It's nice to prolong the life, but do you want to be on the ventilator forever? Is this what you want? Or would you like us to trial certain types of treatments and then stop at some point and to kind of wean you off of those things? Oh, okay. And relief from pain. Except as I state in the following space, I direct the treatment for alleviation of pain or discomfort be provided at all times, even if it hastens my death. You can put more information on that. What we call comfort care in the hospital is when you're basically doing hospice type care. You're saying, this is too much. I don't want all this aggressive treatment. I just give me medication, let me eat, let me do whatever, I can to feel like I'm having some quality here. So they do give you a little space to write in anything that you want to say here. And you have other wishes here that you can add. So let me get to the next page. This is where you can get very specific about donation of organs at death. I did this one. I give any needed organs, tissues, or parts. No questions asked. Do you need it? Take what you can use, right? Or I do not authorize any donations. And some people feel strongly about that, especially if it's tied to religion. I give the following organs, tissues, or parts only, and you can be very specific on that. Oops, sorry, didn't mean to go that far. Uh-oh, okay. Going down to the next section, if you wish to donate organs, tissues, or parts, you must complete this. So is it for transplants? Like take my organ for someone's transplant? Is it for some type of therapy? Are you okay with them doing research? Are they doing this just for education purposes? So you can initial, and before you sign this or have it notarized, you can always initial the sections. It's just the final signature that has to be done in front of a notary or witness. Okay. And it goes down to like My donated skin may be used for cosmetic surgery, applications outside of the US. A lot of people feel strongly about these. For profit tissue processors. Again, people are not happy with that a lot of the times when I ask them. Okay, so that's the advanced directive for healthcare. This is just where you can put in your primary physician. This is where you would sign, as long as you have your witnesses or the notary. This is where the first witness signs, second witness. And this is the notary page. So if you get a notary, you don't need two witnesses. Some people like both, that's fine, it doesn't matter. But it's nice to see the notary because you're not worried about what relationship that person that signed was. Because we're always worried, huh?
I was gonna say, I have a quick question. You might have already addressed this, but where would one get this format? Is it given to you at the hospital?
Yes,
you go?
yes, we have it in the hospital. I put on our the last page of the slides also where you can find it. This is not the only one out there. It's just the one I like to use. So I kind of made this our standard. Some were formatted a little bit differently, but they all have the basic language, I think. This is from the California Hospital Association, and you can print this off. It's nothing special, nothing you have to buy. These are free to use out there. Okay, good question. Living wills, this is just very brief on this. It's a written legal document, spells out your medical treatments. We briefly touched on that it's very specific as to what you want done. I recommend you have a lawyer for this because there are so many aspects of it, and there could be tax implications for those people as well, something to think about. Most of them are typed. You can do it the old-fashioned way where you handwrite your entire will from beginning to end and sign it. That's also legal. I'm thinking that nowadays everything is so complicated that it might be worth spending the money, like $250 for a lawyer to do that for you. I was going to do one online. I printed one out, and I did not like that they did not give me choices of wording. And I just tore it up after I did all that work. I said, I'm just going to go to a lawyer because they didn't give you flexibility. It was either a way or no way. It was like Nolo Press, those type of places. Okay, so that's the living will. Also good. Now Pulse, this is a newer form. Again, I was talking about the serious illness. If you are worried that something can happen and the doctor needs to make a very quick decision, and we don't have time to wonder what you meant by that gray area in the advanced directive. And it's really a lot of pressure on the people you chose on the advanced directive to figure out what that gray meant, that gray area meant. What's prolonged life? What kind of treatment did they want? What's okay with them? Because we don't get into the nitty-gritty on those advanced directives. We're putting all the pressure on that agent to figure it out. And a lot of people don't talk to their agent and say, oh, this is, just so you know, this is what I want. So it is an order. If it's on someone's refrigerator and the EMTs come in, ambulance comes for a call, and they see that you have do not resuscitate on this order, they're not going to. So they're not going to make you go to the hospital. It's important. Yeah. Yes. I saw that, Christy. So yes. So it's good to have it. And they recommend using this hot pink color because it can get lost. It doesn't have to be on special paper. It does not. Copies can be used. It used to be a big deal when people said in the hospital, oh, you don't have the original. I can't use it. I'm like, why can't you use that? And so they revised that to say that copies are fine as well. And it doesn't have to be on special paper. We like special paper in the hospital when we had paper charts back in the day, is because we couldn't see it. It got lost. And we want the doctors and all the staff to see it right away. So let's say you're at home and you want full code CPR, wonderful. They'll probably grab that off the refrigerator or the wall, wherever you have it, and they'll take that in to the hospital. So good to know that we're flexible with how it's presented to us, including skilled nursing facilities and what have you. So it talks about resuscitation, mechanical ventilation. And when I was talking earlier about, do you want to be like this forever, or do you just want a trial period? So this gives you the option for ventilation. Can you try for so long? And usually the ICU doctor will decide, like, what's the reason for all of your diagnoses that you have for your condition, your age, what's reasonable? What's a reasonable amount of time? It might be 2 weeks for one person. It might be a month for another. It really depends. Okay. Do you want to use antibiotics? Is that important to you? So let's say you have pneumonia, you have a urinary tract infection. And those women were like, yes, I want that treated, thank you. Sometimes you have to come to the hospital and get the IV antibiotic because the oral medicine isn't working. Okay, so you come in the hospital for that. What if you have pneumonia? Now you have a fever, you're short of breath. You don't really want to come in the hospital, but this isn't going away. That's where you would check, I want the use of antibiotics. That's limited treatment. And I'll show you what the form looks like. It nicely has a space on this form to say, I have an advance directive. It was done on this date, and here's the person I named. That's wonderful. I love that. This is what it looks like. They call it a POLST form. So if you ever hear that, that's what it is. MDs can do it, nurse practitioners, PAs. So up here, first section, we just go right to it with the patients here. And we say it in a way, if your heart stops, do you want us to allow natural death? Because at that point, right, it stops. It's not an automatic, we have to start resuscitation, but you have to reframe how you say it to people, right? Because your heart's already stopped. Do you want us to back away and not do any more and allow that to happen? Or do you want us to bring you back? And with that, we have to also tell people they're going to be pounding on your chest. It's very hard, and they can crack your ribs. And if you're a frail person, which, we have our 90-year-olds and they're just so skinny and they have other problems. And we're like, oh no, why are you choosing full code for this patient, right? It's sad to see, but if that's what they want, fine, we'll do it. So we always tell them there could be side effects from that. It is painful, and you will have broken ribs, or sometimes they crack the sternum too. So that's not fun. So if you say I want CPR, you're automatically going to have this full treatment box. It's going to include mechanical ventilation, right? There's no time to think when they're doing resuscitation on you. They're going to put the tube in, they're going to do all of that all at the same time. There's some people say, well, let's just see what happens. I'm like, no, it happens in seconds. We have to get this done. So you have to really know what you want. And it's safe for, if you're full treatment, you do have this option of saying, I want a trial period. Don't assume I want this ongoing for a long time. I'm okay if you just do a trial period, and then if it doesn't work, let me go. And that really depends on the individual, their philosophy. Often people that are older that have there's a lot of comorbidities will say, no, I've seen you all enough in the hospital. I don't need to have this prolonged. I'm okay going. I'm fine with that. Selective treatments, what we were talking about, that's, you got that pneumonia, that UTI. I don't want the ventilator. That sure, I'll come in for IV antibiotics or something that's, not quite so invasive. IV fluids, you're dehydrated, something like that, you'll come in. Then you have the other box, comfort focused treatment. That's like your hospice. That's where you're saying, no, just make me comfortable. You can use oxygen. You could do some suctioning. You can give pain meds. It could be oral. It could be, suppository, whatever it is to control pain. This is important for people too that they're on hospice, but maybe their pain's not controlled. They'll come into the hospital sometimes, and it's sad, when you can't be controlled with pain meds from hospice, they're in a lot of pain. So they might come in and they'll have this done. Another section about artificially administered nutrition. That's an emotional thing for a lot of families. Once they decide to put a feeding tube in, it's really hard to stop it, because now you've associated that you're the one who's starving your loved one. So you have to realize once you start something, that's intense, right? You decided on maybe your parent or grandparent that maybe they have dementia and they're just not swallowing well, and you say, I think, yeah, feeding tube's good. You do the feeding tube, but maybe they're still aspirating, meaning, right, that they're still choking on saliva. It happens, when you have dementia, you don't swallow as well. Your brain's not coordinating that motion the way it should. And so they call it silent aspiration. The saliva just goes down into the lungs. It's not going the right way. So even if you do the feeding tube, that can come up as well and go into the lungs. And that's why you'll see people with dementia getting pneumonia. That's the aspiration. So we also warn with that. If you have feeding tubes, it doesn't always take care of everything. That's not always the end all here. You can still continue to have that problem of aspiration, just so you're aware of that. So there's different ways of doing it. So let's say you're a cancer patient, you had radiation on your throat and you just can't swallow. They will ask you, can we do the feeding tube goes through your nose into your stomach? It's temporary. It's a short term. That's great, right? You're that person, it's going to heal. You can go back to eating. Sounds like a good plan, right? You don't need the long-term one surgically inserted. Some people, they have other medical conditions. That's not going to be permanent. And so you might choose, I want the trial period of artificial nutrition. Could be, they call it NG tube, nasogastric tube. You can specify, yeah, I'm good with that, but don't put one permanently in me. Other people are totally alert and oriented. They just have a condition where they need that inserted. They need extra support from that liquid nutrition, but they can also eat some too. So if the majority of their intake is through the tube, then this would make sense for them. But they're still having quality of life. They can go around and do things, but for some reason they're just not able to eat like full meals. So there's some things to figure out on this. Now, if you're end stage disease and you're doing this form, you may just say, no, I already know where I am in my disease process. I don't want to do this intrusive procedure. This is not life to me. I don't want to be fed by tubes. I want to eat. And if I can't eat, I just let me pass, and that's fine. So it's really a personal decision. But this is discussed at length with the physician and the patient. Then signatures. I could, as a social worker, I could go through this whole thing with the patient and fill it out. I work with the doctor to determine if the patient has capacity to make their own decisions. Sometimes it's very obvious they do not, and we go to the legal legally recognized decision maker. Now in California, that's not always the person who has an advanced healthcare directive. What if you don't have one? We will try to find that family member or that person that's super close to the patient, and they will become that decision maker. That surprises people that can actually happen. As you can see in this section, it actually says no advance directive. And you think, well, how can you make decisions for someone without a healthcare directive? Well, I think this was changed because a lot of people did not have an advanced healthcare directive. And so we needed something. We needed a patient. We hope the patient can put down the person that they want, but if they can't, we have to interview. And it's up to us to investigate who might be the best person for that. But if you have an advanced healthcare directive, you put the name, the phone number of the person, all that in there. So let's say I fill this out. I bring this to the doctor and I say, hey, I went through this whole thing. Can you sign this? They'll go in the room and just review and say, is this what you want? Yes, yes, yes. Okay. And they'll sign that. We will give this form back to the patient, and we scan it into our chart, just like we do the other directive. And if someone decides they don't want it anymore, we put a line through it and we make a note. This is no longer wanted, by this patient. We can do a new one if they want to do a new one. But we make sure that we show in the chart that this is no longer their wishes. And there's just a little back portion where we just put the patient's name, and then the physician and whoever prepared it, it'll be on there. Okay, and it does have some instructions right here. Any questions on the pulse form? Does that make sense? Okay, and I put these down in case someone needs to find these forms. These pulse forms come in different languages, so you can print these off. The Advanced Healthcare Directive, this is just the one I use. You could look up any that you like. And then if you're looking for someone, a lawyer, basically to help you with all these, I found the National Elder Law Foundation. So that could kind of help you get those done if it's a little more complicated. Yeah. Any questions on this? I'm at the end of my presentation already, so.
Nice. Any questions? I have a question. I just want to recap on something.
Yeah.
For the post form, we could get that here or from the doctor. And if my notes are clear enough, which I'm not sure, that if we print something like this, or print the form, fill it out, hot pink paper on the fridge, and if we have healthcare director, we can include that.
Yeah, they go together. They actually complement each other. Yeah. Yeah.
Oh, I see. Got it. Okay. So if we have seniors and elderly at home, we should have this on the fridge.
Yes.
Because the emergency crew knows where to look for that, right? And then
now that's only if they have a serious illness that, again, like the doctor would say, okay, it's a possibility they could die from this illness in a year. They're not quite hospice, they're not the 6 months or less, but you could say there's enough going on with them that they could pass. There could be something serious that happens. So not everyone, but there are DNR forms that are just for do not resuscitate only. That can also be put on the refrigerator.
Oh, yeah. Okay. Awesome.
I forgot that one. Yes, there are separate ones just for that as well.
Oh my gosh.
I know there's so many. I know.
Wow. Okay, well, that's great.
Yeah.
Any more questions?
Straightforward.
Yes, it is.
Okay.
A lot of information, but yeah.
And I did put my name and phone number as well as just a general social work phone number. And especially if you know any senior, someone that just had general questions for the social worker, you can start with the that emergency phone number I gave, the our social worker holds that phone usually to work in the emergency department, but it's for the whole hospital. So if someone has a general question, they can call that at any time. We even have people at night.
Right. So if someone doesn't have any of these things in place and they get rushed off to the hospital, whatever the age, whatever anything, there are forms at the hospital that you will have to fill out prior to surgery, prior to, I don't know, if there's an emergency situation, there will be forms there. So
Yeah, there's forms a lot if you're alert and oriented. If you're confused at any time, and we get this from family members, I want so-and-so to do an advance directive now. I said, they're confused. Well, but they're having surgery. I go, no, you can't. If you're confused, it's a legal document. You have to be alert and oriented and understand everything in the document. And I said, that's okay. Don't worry, we'll defer to you. It's, they're worried about that.
Right.
We do have situations where the doctors think one thing should happen with the patient, and like they don't want to do any more treatment on this patient. They're saying, this is horrible. This treatment it's like torture for the patient. I really don't want to do this anymore. But the family's saying, yes, keep them alive no matter what. That's when we have bioethics. I'm part of that too. We have a meeting with the doctors, the staff that's working with them, our risk management, all that, for all the different points of view. When we agree on that, yes, we should do comfort care on this patient, that loved one is not doing what's in the best interest of the patient, we can override that family member and say, no, it's too much. This is, no, you're harming the patient. Yeah, because we also have some interesting ones where spouses don't want to let the person pass because they're getting a check at home. But yes, we see the ugly side of life too. So we're saying, I'm sorry. At some point, you have to let this poor person go. Yeah. So we do see things like that. We do, and some words it's just like they haven't grieved yet. Maybe this is a sudden illness, and we have that with some like 40-something-year-olds. They're in the ICU, and the spouse doesn't want to let go, and it's a tragic situation. We're saying, okay, we're trying to give you enough time, but again, there has to be a cutoff somewhere, because the patient's what we're worried about. Yeah, but we do give reasonable time for family to come from out of country, from another state, just to come say their goodbyes. So we try to make it easier for them. But there's some intense times here where we have to do this with families. So it's sad.
Sure. Wow.
Well,
I certainly, wouldn't want to be in your shoes ever.
Yes.
But
yeah, but any questions though, you can always call me. I can help you, or I can email you a form, whatever you need, if you know of anyone that needs it. But I think we should all have at least the advanced healthcare directive.
Say that again. We should all have at least what?
We should have the advanced healthcare directive.
Yes. Excellent. Okay. Perfect. Any more questions?
Nope.
Okie dokie. Well,
thank you, ladies.
And thank you so much for the presentation. Yeah, this is really important for all of us to know. And the collaboration between you and the chambers are very important. We appreciate that, and we look forward to the next one. We are going to be posting this presentation on our website in the coming days, so be on the lookout for that. And if you have any additional questions, as mentioned, you can contact Manon directly, and she'll be happy to help you there.
Yeah.
Okay.
All right.
Thank you. All right.
Thank you.
Okay, have a good day.
Bye.
Bye.